Good morning. We'd like to start with our first case today. We'll jump right to it and show you these shaved biopsies, which has, go ahead.
I just want to make sure. It's weird that you don't have your little video
The little video's not going. Hold on one second. Maybe it's not plugged in.
No, it's on. Okay.
Okay. So we have a shaved biopsy, and you'll notice this expansile lesion forming multiple lobules. If you look on higher power, the first thing that strikes us is this area here that looks like a cystic area. As we go on higher power, this really draws our eyes because we see this area of necrosis. And if you look closely, you'll see the ghost outlines of cells. Right away, you're thinking maybe this is a malignant process, but what type of malignant process? If we look over in this area, we see thinning of the epidermis overlying this lesion. And we notice right away two populations of cells. We have these basaloid cells, and over here we have these cells that have a more clear appearance on low power. So some of the things in our differential, we're thinking maybe this is a basal cell, it's ulcerated here, it does look like the borders are pushing, but not necessarily infiltrative. These basaloid cells look a bit more undifferentiated than you see for a basal cell carcinoma. There's a lot of cytologic atypia here, and there's many, many mitoses. Also, you notice the clear cells have this vacuolated cytoplasm and large nucleolus in most of the cells. These have the appearance of sebocytes. If we wanted to prove that, we could do a fat stain, but we really don't need to here because we know what sebocytes look like, and this is definitely has the appearance of sebocytes. The basaloid areas are much larger than the areas that contain sebocytes. With this high mitotic count and this geographic or necrosis en masse, we definitely think about a malignant sebaceous carcinoma. And that's what this turned out to be. The clinical photo is very, very nice here. We're showing a typical erythematous nodules or plaques. They may be ulcerated or crusted, and they don't often display that yellowish appearance that we hope to see, but we don't in this lesion. The clinical, you'll have ocular lesions and extraocular lesions. They sometimes mimic blepharitis, ocular rosacea, chalazion, cicatricial pemphigoid, and other non-melanoma skin cancers like BCC or SCC. Histologically, other carcinomas of the skin with areas of sebaceous differentiation, such as basal cells, but typically the basal cells that have sebaceous differentiation turned out to be sebaceomas most of the time. So usually you can tell because the areas are so much more undifferentiated in the sebaceous carcinoma than you would see with a basal cell with sebaceous differentiation. Sebaceomas typically don't have that high degree of atypia that we saw in the previous slide, the high NC ratios, the nuclear pleomorphism, the lack of a great deal of cytoplasm in the basaloid cells. There was one area on the other slide, I don't know if you looked at the slides beforehand, but there was one area where there were a couple of pagetoid cells where you saw the lesion exhibiting Paget's like changes. But the differential for these tumors does include Paget's disease and melanoma if you only have the surface of the lesion. So you have to be very careful. You may need to stain it. One of the things we need to do when we get a sebaceous carcinoma is that we need to do stains for microsatellite instability to detect if this may be related to Muratori syndrome. So some of the stains that we can do at our lab is MSH2, MLH1, and this should be MSH6. It should be an S here, and PMS2 expression. So if we see that at immunohistochemical staining, there's evidence of microsatellite instability in the tissue, and therefore you need to get the patient possibly a GI consult because they may have, colonic polyposis. So if your lab doesn't do it reflexively, you can ask the pathologist when you get sebaceous carcinoma to do these stains. They could send it out if they don't do it at their laboratory, and we do it at this laboratory. So we can do those stains, and we do it reflexively. Typically, the nodules are erythematous. There's plaques. They may be ulcerated or crusted, as we mentioned before. They may have an erythematous or pearly morphology. The ocular location is very typical for these, but you can see it in an extraocular location, typically in the head and neck. May rarely be associated with the Muir-Torre syndrome. The histologic features are the small basaloid cells, which I think are more undifferentiated than basaloid. You can see some squamous differentiation. So if you see that focal keratinization, don't get bothered and say, oh, this is a squamous cell. Foci of sebaceous differentiation, you might see the finely vacuolated foamy cytoplasm, which we did see here. So our tumor was more well to moderately differentiated based on the grading system, because we still have, sebacites. Our tumor did have asymmetry. There was a lack of circumscription in that it was multiple nodules. And there wasn't a great infiltrative pattern, but that still doesn't mean our lesion wasn't malignant because of the high mitotic count. When you're counting mitoses, go to the most mitotically active areas. And also necrosis en masse is very characteristic of malignancy. So that was a big help there. So we didn't see as many jagged nests and thin strands, but we did have the large nodules. And when it involves the epidermis, you can see that pagetoid pattern or a buckshot scatter, especially in ocular lesions. So moving on to the next case, we have a punch biopsy that's somewhat fragmented here. Right away, we notice the area down here where we have fat, or what was left of the fat. Our eye is immediately drawn to this area. And we notice that the lipocytes are gone. We have an eosinophilic areas, but we also have basophilic areas over here and here. And this is where the free fatty acids in this entity basically take up the calcium salts, and you get these very characteristic basophilic areas in this lesion. So this is a lobular paniculitis. I mean, there's absolutely no evidence of much of the fat that's left over. Up here in the dermis, we're seeing inflammation and some sclerosis, acanthosis, histiocytes, lymphocytes, some hemosiderin. So there's some hemorrhage that has been going on here. We don't see ulceration in this lesion. Clinically, we have an appearance of multiple painful erythematous nodules and plaques that may fluctuate, ulcerate, and an exudate that's brown yellowish, and an oily substance can sometimes come out of these lesions. So this was pancreatic paniculitis. The clinical is you have a differential of all other types of paniculitis, and histologically, this liquefactive fat necrosis, those basophilic areas, is very, very specific finding for pancreatic paniculitis. Again, we'll see the multiple painful nodules and plaques that may fluctuate, ulcerate, and the exudate is usually brown, yellowish, oily substance. Schmidt's triad, the 3 Ps, where you have paniculitis, pancreatitis, polyarthritis, eosinophilia, very, very poor prognosis. Histologically, we had that beautiful lobular paniculitis with that intense liquefactive fat necrosis. There's basically no lipocytes left. The eosinophilic degenerated adipocytes surrounded by calcification with rimming. And there was not much granulomatous rimming left over. There was a little bit in the dermis, but we didn't see that great granulomatous rimming. But then again, the punch was fragmented. So that was a beautiful case of pancreatic paniculitis. Nothing really can do that, not even trauma, with those basophilic areas. But as the lesion gets older, the basophilic areas disappear, and it does get harder in the older lesions that become more eosinophilic. So it gets trickier when the lesions get older. But typically this is acute pancreatitis, so it's a very fast phenomena. This is a very gorgeous punch biopsy. And what we notice right away is that the annexae are preserved, but we see this population of cells and not much of a Gren zone and not much involvement of the overlying epidermis. But we see a lesion that's taking up the entire upper lower dermis and the paniculus. It's activating into the paniculus. And we see this honeycomb or Swiss cheese pattern where the cells, these plump fibrohistiocytic cells, almost fibroblastic cells, are infiltrating in between the collagen and into the fat. So this honeycomb and Swiss cheese appearance is very characteristic of this entity and the sparing of the adnexy. We don't see any pigment in this area. The cells are a bit plump, but they are they're also uniform. So we don't see many mitoses. If you look around, there's not many. Clinically, we see a lesion that can be plaque-like, surrounded by a red to blue discoloration, more commonly on the legs. So this was a dermatofibrosarcoma of childhood. Clinically, the differential includes tumors and vascular malformations, dermatofibromas, infantile myofibroma, and rhabdomyosarcoma, and keloids. Clinically, this plaque-like lesion on the skin can be surrounded by a red-blue discoloration. It resembles a birthmark. It can be congenital and present in young children. It's a slow, persistent growth over a long period, often several years, greater propensity to affect the legs and apical regions, and it can be congenital. Fibrohistiocytic tumors of intermediate malignancy. There's uniform spindle cells with elongated nuclei, little or no pleomorphism, and scanty pale cytoplasm. The key feature, though, to differentiate it from the DF is the storiform pattern, sort of a cartwheel. It wasn't very well exhibited in this tumor, but there was sort of a whirling pattern, sort of mat-like pattern, and centered around the small blood vessels. The adnexal sparing we did see here, and the mitotic figures, they were definitely below 5 per 10 high-powered fields. Immunohistochemistry could be very important here. You would like to do a CD34 stain, which would be positive, and the factor 13A would be negative, which would be reversed in a dermatofibroma. You would see in a dermatofibroma negative, typically negative for 34, and typically positive for 13A, but there's always exceptions. There's a translocation of the 1722, which is similar to what you see in adults. And you also have a fusion gene of the COL1A1 and the platelet-derived growth factor beta fusion gene. And you can see ring chromosomes are mainly observed in adults, whereas translocations are present in all the pediatric cases. So you can do FISH for the fusion gene, and that can help you determine if this translocation is present. The next case that we had is very interesting and quite unusual and rare. We have a punch biopsy here, and as we notice, this expansile lesion is not connected to the epidermis in these sections. It has a very much of a nodular pattern. As we get on higher power, we notice there's innumerable duct-like structures throughout this lesion. And these duct-like structures seem to be lined by these cells that are somewhat cuboidal with eosinophilic cytoplasm. And you have this proteinaceous material in the center of the lumens. And in some areas, you can even see this decapitation secretion. Typically, you'll see this in African lesions. And this lesion is a hybrid adnexal tumor, which is showing features of a nodular hidradenoma as well as a tubular African adenoma. Clinically, they typically, most of the time, appear on the scalp as this nodule that's pinkish to red dermal nodule, sometimes pedunculated, but usually more of a nodule. Again, this was a hybrid adnexal tumor, hidradenoma with areas of tubular African adenoma. The differential is other benign adnexal tumors, cylindromas, that should be a Y, a syringocystadenoma papilliferum, that should have another L, and the cysts, pilar cysts and dermoid cysts can mimic this clinically. Benign vascular lesions also. Histologically, syringocystadenoma papilliferum will be coming down from the surface, and hidradenoma papilliferum. Papillary eccrine adenoma. I don't think this looks like this at all, this entity, because you don't see the papillary areas, and this is more of an African duct-like structures rather than eccrine, because you see the decapitation secretion. And papillary African carcinoma, well, you would see more of an infiltrative growth pattern, a higher mitotic rate, and a higher NC ratios. The last slide goes over the clinical features again with the dermal nodule. Typically, they're 1 to 2 centimeters. This lesion was over a centimeter in diameter. They usually stick around for many, many years. It's most commonly on the scalp and arises in a background of nevus sebaceous and sometimes associated with pharyngocystadenoma papilliferum to further cloud the picture. Histologic features, circumscribed intradermal nodules with an overall lobular architecture. There's well-formed tubules lined by the double layer. It was very difficult in that slide to see the myoepithelial layer, but typically you will see cells that are smaller and more oval in appearance at the base of those ducts. And those are those flattened, they're more flattened myoepithelial cells. Here we didn't see much pleomorphism. Now you can see mitoses, but this did not have a very high mitotic rate, which confirmed the benign nature of the process. Next case is another punch biopsy. And we have a very dramatic process here that's taking up the parts of the upper dermis and the lower 2/3 of the dermis. The process is somewhat in a parallel configuration, somewhat tiered. Layering, you get the feeling that there's layering going on. Also, the involvement of the pedunculus is very, very helpful here. You'll see these thickened septae. This punch biopsy gives you a little bit of a clue on what location. You're seeing some increase in small vessels here in the papillary dermis. So you think about possibly this being a location on the legs because you're seeing some stasis change here. But the most important process here is in the dermis, and you're seeing some sclerosis, and you're seeing areas of this sort of pale degenerated collagen, and these areas are appreciated over here in this area of the slide, these pale degenerated areas. This is typical for necrobiosis, and there's some inflammation around it. The inflammatory cells are more epithelioid. You don't see the foamy cytoplasm that you see in xanthomatous processes that can mimic this. There weren't many giant cells here, but there is a feature that's extremely helpful. You'll sometimes find vascular changes in this process. For instance, there's some vascular changes here where you'll see some inflammation around the vessels. You often don't see frank vasculitis, either lymphocytic or other vasculitis, but at the interface here, you'll often see plasma cells, which is a very helpful clue. Also, the fact that there isn't much mucin, there's more necrobiosis than mucin. But with this straight edge on the side of this punch biopsy and this cake layering phenomena, also the thickening of the septae in the pedunculus is very, very characteristic of this entity, necrobiosis lipoidica. On higher power, you'll see this yellowish hue to this plaque. They're active, well-demarcated, raised, firm border, and depressed atrophic center in the pretibial region on the shins, lower leg. And here you have a more area that's got a little bit of scarring and atrophic depressed areas on the right. So this is a later lesion on the right. The differential includes granuloma annulare, but in that entity, clinically, it can mimic granuloma annulare, necrobiotic xanthogranuloma, sarcoidosis, annular elastolytic giant cell granuloma. Histologically, granuloma annulare, you'll see much more mucin. Necrobiotic xanthogranulomas, you'll see more giant cells. Elastolytic giant cell granuloma, you'll see the giant cells engulfing the elastic fibers. Actinic granuloma, you'll also see the giant cells engulfing the elastic fibers. Rheumatoid nodule, again, it'll be deeper, more located in the subcutis. You'll see areas of necrobiosis and more palisading than you see with necrobiosis lipoidica. Rheumatoid nodule location is another key factor on the extensor surfaces. Olecranon area is more typical for rheumatoid nodules. So you need some clinical path correlation at times, especially if the biopsy is small. Next slide. It starts as a brownish red skin colored papule that evolves into a well-demarcated waxy plaque. There's sharply defined and slightly elevated borders, retain their brownish red color. The center becomes depressed and acquires a yellowish orange hue. Through the shiny and atrophic epidermis, there's multiple telangiectasias of variable size are seen, and later, after ulceration and healing, presents with extensive atrophic depressed scarring, usually in young adults on the shin. Again, the histologic features that are so characteristic are the pale degenerated collagen between the layers of inflammatory cells, those epithelioid histiocytes rather than foamy histiocytes. You'll see multinucleated giant cells. We just don't see that many here. And the key plasma cells at the border of the subcutis and the lower dermis. The inflammatory process is oriented parallel in a parallel configuration, that so-called cake layering pattern that Ackerman always talked about. Again, there's a strong association with this disease. Approximately a third of the patients have clinical diabetes, and 1/3 of the patients have glucose intolerance. Another third may have normal glucose tolerance. Control of the diabetes has absolutely no effect on the course of NLD. Next case is a very interesting case. We have a very small punch biopsy. And right away, we see these blue cells throughout the dermis and the lower dermis and into the panniculus. On low power, you notice that the cells are very discohesive, which right away you're thinking that this is more of a lymphoproliferative process rather than something like a Merkel cell, because you see the discohesiveness of the cells, and that's very typical for lymphomas. The cells are discohesive. And that's why we have to be very suspicious here of an atypical cutaneous lymphoproliferative process. In the past, we used to say that, oh, well, it's bottom heavy, and that's a sign of malignancy, but you really shouldn't do that because you really have to work toward proving clonality. But this is a definite diagnostic dilemma for many pathologists, and everyone's trying to figure out a good way to be able to determine what type of lymphoproliferative process this is, and to rule out a benign process and rule in a malignant process, and what type of malignant process. But we're very suspicious on this lesion because you have nodular areas and then you have diffuse areas. You don't see anything to indicate what's causing this process. You don't see any follicles or cysts or keratin debris. You don't see any giant cells. The population is consisting of many small lymphocytes with irregular membranes. I wouldn't exactly call them cleaved, but the membranes are irregular. And some of the cells look like lymphocytes with a more monocytoid appearance. Other cells have histiocytic appearance, and then other cells look like they might have a more centroblastic or centroimmunoblastic appearance, but very few of those cells are seen. I would take an RBC when you get these cases and use that to judge how much bigger these cells are than a regular lymphocyte, because these may not be regular lymphocytes, they may be atypical lymphocytes. So you have to determine their size, and most of these cells are small to intermediate in size. So now how are we going to go about proving whether this is a malignant or just a pseudolymphoma or cutaneous lymphoid hyperplasia? Well, we definitely need to put some stains on this. Typically, we'll do a CD20, a CD3 to see how many of these cells could be reactive T cells around in this area. Clinically, let's look at the very important to look at the clinical on this. Obviously, we have a group of red violaceous indurated plaques nodules or tumors. So we have multiple nodules here, which is a very important finding. This did turn out to be a marginal zone lymphoma. I don't have the stains to show you here, but the reactive conditions that can mimic it are cutaneous lymphoid hyperplasia, the so-called pseudolymphoma, and an arthropod bite, which is clinically only. In that lesion, we didn't see many eosinophils at all. Primacutaneous follicular center lymphoma can be in the differential for this histologically, as well as a diffuse large B-cell lymphoma. In this case, we did not see many cells with large nucleoli. And larger, 2 to 3 times larger than a regular lymphocyte. So we didn't see many large cells. So we would place this in more of the smaller cell to intermediate cell category. So pretty much we can eliminate the diffuse large B-cell lymphoma. Also, we have to worry about in the differential the secondary cutaneous marginal zone lymphoma, which this turned out to be the so-called MALT lymphoma, which you can see in the skin and obviously many other organs in the body. Alrighty. The clinical features, it presents as a solitary or regional group of red to violaceous indurated plaques, nodules, or tumors. It's more common in middle-aged women. It's an indolent B-cell lymphoma with an excellent prognosis when it's in a primary cutaneous lesion. There was a dense nodular dermal and subcutaneous B-cell infiltrate. There was a small Gren zone, but most of the time the cells are composed of centrocytes. They have cleaved nuclei, and I tend to not, you really don't see the cleaves. They have irregular nuclear membranes. It's better to think of it that way. Dispersed chromatin and inconspicuous nucleoli, which is very important to distinguish it from a large, diffuse large B-cell lymphoma. There's also some pale cytoplasm, and some of the cells can look more monocytoid. So they either look centrocyte-like or monocytoid in appearance. And then you can see, which is very helpful, the lymphoplasmacytoid cells or frank plasma cells. You can see zones of neoplastic plasma cells in more than 2/3 of the cases. And we didn't mention it here, but you can sometimes see the internuclear inclusions, the so-called Dutcher bodies, which are very, very rare, but if you see them, they're extremely helpful. One thing we did not see in our case was the lymphoepithelial lesions. Usually you cannot rely on them, but typically with marginal zone lymphomas in the skin, you sometimes will see them going into the adnexal structures or even the eccrine epithelial lining cells. In this case, we didn't see many reactive germinal centers. They can be very helpful if you see them, because the cells in this marginal zone lymphoma will populate the interfollicular areas and around the reactive germinal centers. So if you see germinal centers, look for the tingeable bodies and then look at the cells around it in the interfollicular areas. But we didn't see any of that in our case, so we didn't have that to help us out on what type of lymphoma this is. Occasionally you'll see the scattered centroblasts and immunoblasts from the disrupted follicle centers. But in this case, we don't have the T cell stain to look at, but you can occasionally see CD3 positive T cells surrounding the malignant cells. What we can do is the BCL2 stain. If the BCL2 stain is positive for those centrocyte or monocytoid cells, then we can definitely push it into the suspicious for marginal zone or MALT lymphoma. In this case, the BCL6 is negative. If it's positive, you think about more of the follicular lymphoma. This monotypic light chain expression, sometimes we can do a kappa lambda immunohistochemistry, but we found it to not be very helpful. We were very hopeful many years ago that we were going to do the kappa lambda light chain immunohistochemistry, and we'd see a predominance of kappa staining or lambda staining, and we could say, great, we're proving monoclonality here, and slam dunk, we've got our answer. But it just never works out that well on the immunohistochemical stains. But I still have hope, so I do it routinely when I suspect these indolent B-cell type lymphomas in the skin. Another thing I forgot to mention is always examine your epidermis and look for epidermotropism, because you always want to rule out a T cell process. And that's a good, helpful clue to rule out a T cell process. Oh, also too, the CD5, 10, and 23 were all negative in this case. So that can be helpful too, to lean toward a marginal lymphoma. We have a punch biopsy. And the most striking feature that we see right away is that this is coming from volar skin. But we also notice these vesicles, subepidermal edema, and these vesicles draw right away. My eye is drawn to these areas, and I also see some inflammation in these areas. Some of them are lymphocytes and occasional neutrophils. So we have some pustules here. and they're widespread. So this is a very incredible slide. We're also noting a lymphohistiocytic population and scattered nuclear dust. We're seeing some neutrophils in here, not many, but this other striking feature is the hemorrhage. I mean, we're seeing hemorrhage, and that's making us think about a vasculitis. So right away, with all of this hemorrhage, and this is not procedural, this hemorrhage. You have hemorrhage up here. You also have hemorrhage over here by this vessel, and hemorrhage here. Right away, my eye is drawn to this obliterated small blood vessel, and possibly there's some fibrin platelets in RBCs in this area. Also over here, you notice that this might be another obliterated vessel, and with all this hemorrhage around it, must have a striking clinical appearance. My eye is also drawn to this almost small, it looks like a small arterial artery. The endothelial layer is sort of irregular and wiped out. If we did a stain, we might even see organisms in this area. We might be able to do a tissue gram stain, which is a Brown and Bren, which doesn't tell you gram positive or gram negative, but it will highlight the cocci. So if you look in these areas and you find small, very tiny, so I can't even go high enough with this whole slide imaging and this zoom process to find them, and I don't have the Brown and Bren stain to show you, but there's some fibrin in this area, some inflammation in the wall. There's even a nuclear debris here from possibly a broken up neutrophil. So we have vascular changes here. We have a vasculitis here. Clinically, this had a very striking appearance where you see pinpoint petechiae, and you have pustules, and you even have a bullous ulcerated process here with bullous hemorrhagic, actually hemorrhagic, and there's purpura here. Also, you have lesions on the palm, which is very characteristic of this entity. What we have here is a septic vasculitis. Histologically, it does clinically depends on the etiology, but there are other types of LCV, leukocytoclastic vasculitis, usually regular LCV, cryoglobulemic vasculitis, Henlock-Schoenlein purpura, urticarial vasculitis, and eosinophilic vasculitis, which you can see with hypereosinophilic syndrome and some connective tissue diseases. Typically with cryoglobulemic, you'll see PS positive material in the vessels. But you definitely need clinical history. Do they have cryoglobulinaemia serologically? This was a septic vasculitis, most likely Neisseria meningitidis, meningococcal entity. Hold on one second, let me get to the next slide. So this is really a variant of acute vasculitis because we saw some neutrophils. It's an association with septicemic states. Meningococcal, gonococcal, pseudomonas, streptococcal, infective endocarditis. Mainly, you'll see staph organisms with infective endocarditis and some cases of secondary syphilis, which we're seeing a lot of. The clinical presentation will vary. Most of these cases are meningococcal. You'll see erythematous macules, nodules, plaques, petechiae with or without pustules on extremities and pressure sites, and features of DIC. Gonococcal, we'll see pustule lesions on the digits, pseudomonas, hemorrhagic bulli, ulcers, and eschars. Infective endocarditis, we'll see the Osler nodes and the Janeway lesions. The Osler nodes are painful, and the Janeway lesions are typically non-tender. On the palms and soles and the hands and feet with the Osler nodes. The histologic features of acute meningococcal septicemia, that's about 80% of the cases. You'll see widespread vascular damage, neutrophils in and around the vessel walls, and as well as some in the interstitium. Mild leukocytoclasis. I didn't see much in that slide. I saw lots of perivascular hemorrhage. I saw minimal degenerative changes of the nexal structures, but I did see the pustulation and the intraepidermal pustules and the subepidermal edema and vesicles forming. There were, in other cases, large numbers of gram-negative diplococci. I couldn't see on the H&E the diplococci here, but when you look for them, look in the endothelial cells and look in the neutrophils, and that's where you'll find them. Chronic meningococcal and gonococcal septicemia, the arterioles are often affected in addition to the venules, and the deep vessels may also show changes. There's conspicuous extravasation of erythrocytes, admixtures of mononuclear cells, vascular thrombi are more regularly seen, and leukocytoclasis is often present but not prominent. There's a regular presence of subepidermal and intraepidermal pustules, partial destruction of the epidermis, and organisms are usually not found with meningococcal and gonococcal, although bacteria antigens can be stained with immunofluorescence, and we can use immunofluorescence to detect the organisms there. Infective endocarditis, obviously you see the painful osseous nodes on the hands and feet, and the Janeway lesions are more embolic suppurative process with or without vasculitis. The organism may be found in the microemboli and the Janeway lesions. So it's very interesting with infective endocarditis. Our next case is taking us to a completely different area. Let me just slowly spin this around because it's upside down. For those of you who like to have the stratum corneum up, which I like to always put it in that direction, keeps you organized. One thing you notice about the shaved biopsy on volar skin, you notice that there's not much inflammation here. So as you're looking around to make your diagnosis and you're going from bottom to top or top to bottom, I like to start at the top, which is good because in this case, when I start at the top in this somewhat compacted keratin layer, I notice right away it's teeming with organisms. And you can see here, there's innumerable hyphal organisms. Some of them are branching and they have septae. I don't see many spores, but I see mostly hyphal organisms and hyphae cut in cross section, which are not the spores, but they're actually the hyphae. If you want to see spores, you might want to do a PAS on this case. But what you do notice is the walls are thick, and you notice a brownish hue to some of these hyphae. Obviously, they're showing up very, very well in this H&E stain. So some of the things that we like to think about is obviously tinea, but this is a certain form of tinea that gives this very characteristic clinical appearance of a tan macule on the plantar foot. It was present for several years. Some people may look at this and say, wow, this looks like, MIS. I need to biopsy this, and then they get back the diagnosis of tinea nigra. So that's what that was here, tinea nigra, Horteye Werneckii. The clinical is the MIS or differentials melanoma in situ, talon noir, which is the black heel, which is hemorrhage in the stratum corneum, can mimic this clinically. And you can also have silver nitrate stain, which we don't see that often because obviously people are not using that type of photographic developing anymore as much, in their houses or wherever. Histologically, the differentials, other pigmented fungal infections with chromoblastomycosis, you usually see it in the dermis, the copper pennies, and that we did not see at all here. This was a process that was in the stratum corneum. Phaeohypomycosis, some people used to categorize tinea nigra into that category, but you can see a pigmented phaeohypomycosis. You again could do cultures if you want to differentiate some of these things. This was a slowly enlarging brown to black macule or a large patch involving the palms or plantar surface of the fingers. Sometimes they can be bilateral, and they're more common in tropical areas, and children and adolescents may be involved with having these lesions. The histologic features, the stratum corneum might be slightly more compact. You have the numerous brown hyphae are present in the superficial layers, and we did see that here. It was more in the superficial layers of the stratum corneum. And they were easily seen on H&E stain, which I loved because we didn't need the PAS. If you want to look for the spores, you can, but I think with that brown hue, we can just make the diagnosis of tinea nigra. And we didn't see much of an inflammatory reaction in the dermis or even in the epidermis. This next case is a really beautiful section of this entity. Now, this may have been one lesion bisected, or it may have been 3 lesions that they placed in the formalin container. I'm thinking maybe there were 2 lesions, or this was possibly bisected. But taking a closer look at this, we notice right away the hyperkeratosis, the acanthosis, and the downward projection of these rete that are increasing and bridging. they're increasing in thickness and they're bridging. But the most important part of the process is obviously in the dermis here. We're seeing sclerotic areas of collagen, and some people would say, well, it's vertically arrayed. And it is somewhat vertically arrayed. It's more going in this direction. And we do see prominent vessels here. When we look at these cells, we notice they're not terribly atypical. They're not very pleomorphic. They're somewhat stellate in appearance. If you look in these areas, you'll see they might have little points on the end. So they're somewhat stellate. They're plumper, a little bit plumper than usual, but I wouldn't call this a cellular entity in this connective tissue area of the dermis. So this is this entire dome-shaped papule is the entire entity, and this is very good for a periungual fibroma. We notice there's no nerve, and be careful, please look for nerve. You need to look for nerve down here because you don't want to miss an accessory digit, supernumerary digit, because with those you'll see nerve in that area, but this doesn't look anything really like that. It has more of an angiofibromatous appearance. But clinically, the most important thing is you'll see multiple skin-colored tumors emerging from beneath the proximal nail fold associated with longitudinal grooves in the nail. So this is beautiful for Conan's tumor, a periungual fibroma. Clinically, isolated ungual fibrokeratoma, pleomorphic fibroma, which you'll see more pleomorphic fibroblastic cells. In infantile digital fibroma, usually you'll see fibromatosis and some inclusions, and this was not looking like a verruca vulgaris at all. You don't see any viral cytopathic effects, and you don't see any papillomatosis. And also you have the area in the dermis, which is why this isn't just a wart. And the supernumerary digit, well, we don't see any nerve, so we're not thinking about an accessory digit. Histologically, it's indistinguishable from an isolated ungual fibrokeratoma variant. And pleomorphic fibroma, you want to see more pleomorphism of those cells in the dermis. Clinical features, multiple sub and periungual fibromas associated with tuberous sclerosis. So this is very important because it can occur in 50% of the patients with tuberous sclerosis. Rarely, it is only clinically manifested. It's the only clinical manifestation of tuberous sclerosis. So this may be the only thing you see, and you can make the diagnosis of tuberous sclerosis. It usually starts to grow at, around puberty and early adulthood and progressively increase in number and size. It's more common on toenails, and it can be considered a variant of fibrokeratoma. Histologic features, there's no difference from isolated ungual fibrokeratoma. It also can mimic the acquired digital fibrokeratoma. Some people like to lump all these into the acral fibrokeratoma group and not split everything up. But I think it is important clinically to split things up and to determine clinically what you're seeing and fine-tuning it with your clinical. So we saw a somewhat dome-shaped, it wasn't really pedunculated, but it was more dome-shaped fibroepithelial lesion. There was hyperkeratosis, acanthosis, and branching rete, and the core was composed of fibroblasts and dense collagen fibers with that vertical orientation. The vascular component was somewhat prominent here. All right, our next case is actually what we're going to do is we're going to stop here, and we're going, because we had quite a few cases today, we presented 11. So we'll stop here, and the next time we'll continue to present the rest of the cases. What I would like you to do is if you have any questions, email me at vray@dermpath.com, and that way I can spend some time answering your specific questions, specifically about the slides that we showed here. You can go back and examine them very closely with the whole slide imaging and see if there's any things that you'd like to bring up in the differential. Just shoot me an email. I'll be happy to answer any of your questions. Anyway, thank you for enjoying this lecture. I hope you enjoyed it. Take care. Bye.